Hello and welcome to this Hoosier Extracorporeal Science Conference brought to you by Heartbeat Perfusion Solutions, which is a national provider of specialized perfusion and extracorporeal membrane oxygenation services. I'm your host today. My name is Sam La Liberty. And today we have a really incredible guest with us. We have Dani Tost, who is the CEO and co-founder of Vermedex Virtual Experiences, which is a deep tech startup. Dani has a PhD in industrial engineering and decades of experience as a professor and researcher in computer graphics and biomedical simulation. She's been a leading voice in the field of serious games, AI, and VR for healthcare training. Throughout her career, she has directed multiple European R&D projects. She's mentored new generations of biomedical engineers and pioneered simulation technologies that bring accessible, high-impact medical education to professionals worldwide. Her leadership at Vermedex reflects a passion for merging science, creativity, and empathy, redefining how healthcare training is delivered in the digital age. So Dani has prepared a presentation and a case study on her work with simulation in healthcare and will be providing an introduction of VR in perfusion and ECMO education. Following the presentation, I will return. We will do a fireside chat to go deeper in some of these topics. Dani, thank you so much for joining us today.
Thank you. It's my pleasure.
We are delighted to have you. The floor is yours if you would like to share your screen and walk us through your presentation today.
Perfect. I'm going to share and great.
That looks great.
Good. So thank you very much, Sam, for the introduction. I'm going to, okay. Great. So these are the objectives of the talk today. First of all, let's talk a little bit about why we need simulation. We are going to talk about the types of simulations and simulation specifically in extracorporeal circulation. And finally, we'll have a little demo. What's the problem? Healthcare technology has been shown to be an important investment because it allows to shorten and decrease the cost of hospitals and in general management of health. So this is why in the last years, because the technology was evolving and because there is an interest from the healthcare institution to have this kind of technology, many devices have been introduced in the routine practice of clinicians, of nurses and doctors. Currently, there are about 3 million of connected medical devices within hospitals. About 3 million, that's a huge number. And from those, digital and smart devices account for 40% of the new purchases in equipment. It's a growing market. The devices are each time more complex and they evolve constantly. But what's the problem? The problem is this evolution in the acquisitions of equipment has not been accompanied by an evolution in the way our clinicians are trained. Nowadays, most of the training is a little bit similar to this painting from Charcot, which is a painting from the beginning of the 20th century. Charcot was a neurologist, and what happens, most of the people were studying by looking at him with, and this is the importance of this painting, the patient in front of them. If we analyze the statistics, 20% of training includes, only 20% of training includes hands-on practice. 70% of medical professionals report that the traditional lectures fail to prepare them for real-world scenarios. And 80% of professionals are not exposed, and this is another key point, to high-risk, life-threatening cases during training. So this is something that must be changed. The basic principle in medicine is primum primum non nocere, so first principle in medicine and nursing, do not harm patients. This situation, an outdated training has consequences. And one of the consequences is on errors that are done, especially in these critical situations for which we are not prepared. There are around 20 to 40 million medical errors worldwide. Not all of them, of course, are due to a lack of training, but part of them are due to a lack of training. These errors have a very important cost, 42,000 million of cost every year. And this is also very important, it has an emotional impact on our professionals. 45 to 55% of nurses and physicians report having experienced at least once in their life a very severe sensation of burnout. And it's not only for the conditions of their work, which is very stressing, but it's also because after an error, they feel very guilty and they have a lot of problems to go further and accept that this error was committed. What's the solution? The solution is quite easy. It has been demonstrated that simulation-based training improves clinical performance by up to 20 to 30% in compared to traditional instruction. So the idea is to use simulation, so a technique that creates a situation or an environment that allows to experience, but in a scenario that is not the real one. So simulation is the solution. It allows us to increase knowledge, enhance soft skills, in particular communication, decision taking, and problem resolution. It strongly reduces the learning curve's steepness, and it allows clinicians to be exposed to multiple cases, especially those that are infrequent. There is a difference between knowing a lot and being an experienced professional. An experienced professional has been exposed to a variety of cases, and it is difficult to have this exposure if you in current days, because some of these incidents are rare. So the rationale behind simulation is learn through repetition. You can repeat as many times as you want a scenario. With errors, because we learn from errors. So the idea of simulation is to learn commit as much error as you can, because you are in a controlled, safe, and the most important thing, patient-free environment. The idea is to avoid situations such as the painting. Of course, the painting was a little exaggerated image, but it's the concept. So the idea is you train without patience, and then once you have been exposed to all kinds of situations, you can go and be in front of a patient. And this does not affect only young students or young residents. This is something that should be done live through. Why? Because, as we have said at the beginning, medical devices are evolving. There are new medical devices, and the medical devices that we already know are evolving constantly. So this is something that we need to do very, very frequently. This seems obvious. And in other risk professions, such as piloting planes, this has also been recognized. But if we compare the budget of the budget devoted to simulation in professions like pilot simulation, in comparison to medicine and nursing, it's incredible the difference. 40% of the budget of aviation is devoted to simulation, whereas it is in a good case, I would say that these statistics are a little bit optimistic. It's only 5 to 7% of the budget of simulation. And I've said that it was optimistic because this is a percentage of the budget of large hospitals. For small hospitals, it's less. So why, how can we explain this difference? Why do we have mm, such a gap between other risk professions and medicine? It's not a problem of history, because we know that the idea of having simulation is as ancient as 600 years before Christ. Uh, it was Sushruta, an Indian physician and surgeon, who created the first simulator. He used clay, wax, and G to simulate human tissues, and it fostered the use of students. It fostered students to practical surgical techniques, in particular cutting, dissecting with uh, kind of mannequins, the mannequins that they had at that moment of time. So the idea of the need of simulation is as ancient as the idea of healthcare. Uh, Two other examples. This mannequin is in a museum in the University of Salamanca in Spain. It was created in the 16th century to teach to the medical students. It was one of the first medical universities to teach them how to make bandages to patients and how to immobilize members in case of fracture. So again, and this is something that I especially like. Uh, it's a mannequin, the first obstetric mannequin. It was created by a midwife called Marguerite Le Boursier. And you can see that she had um, like little dolls that represented fetus, vaginas, and all what needed to train midwives to assist birth, to assist birth. So the key ideas here is really medical training more than even need simulation. Simulation has always been part of medicine. However, it is not as used as it should be. But here are the good news. If we analyze what the market says currently, we can see this is from market and from markets and markets. If we analyze the healthcare simulation market, it is clearly raising, and we expect by 2030 to have a very huge increase of the market size in simulation in all countries, and in particular in North America. What are the drivers of this movement that will put healthcare at the same level as other risk professions? The drivers are that the demand for a simulation is really rising in educational environments, but also in the hospitals. And because these rapid technological advancements need us to go faster. What are the limitations that are probably the reason why simulation has not been so widely used? Limited availability of funds, but this is something that is changing. Hospitals nowadays understand that they need to invest in simulation, and this need is pushed through the responsibles of the hospital by the final users. So it is you, clinicians, perfusionists, nurses, who should ask your hospitals to invest in simulation. And the other reason that can make simulators not adopted globally is that some of them are poorly designed, but this is also something that is changing, especially with the advent of the new technology as the ones that we are going to review today. So basically, these are the challenges, these are the opportunities, and we are at the right moment in the right place. Okay, let's talk a little bit about simulation now in the healthcare. There is a concept in the world of simulation that is called mixed reality. It's a concept that was created by Milgram in 1994. It's called the reality continuum. So at my left, it's reality, the tangible world, the thing that we really can touch. And at my right, it's virtuality, the things that are in the domain of the imagination, of the abstract. Well, what Milgram said is there are no two realities. There is no such difference between reality and virtuality. There is a continuum. And so from reality to virtuality, we can go through steps of each time more virtual realities, and in the other side, each time more real virtualities. And this concept is applicable to simulation. Let's see how. Reality. So something very tangible is, of course, role-playing, talking with actors that simulate the behavior of a patient or the behavior of a nurse or the behavior of a family, of the family of a patient. So this is a kind of simulation that is, of course, not real because it's a simulation, but it's more tangible, it's more near the reality in the sense that this is something that you can really touch. These kind of simulations are based on actors that we hire. Then we have augmented reality simulators. Augmented reality simulators simply add a layer of virtuality on top of something that is really tangible. For instance, in this example from augmentedreality.health, you have a phone that you put on top of a foot, and you can see the blood vessels behind the foot. It's just a question of projecting the anatomical information of the underlayer of the level underlying and have this information. So here we enrich the reality with virtuality. Then we have task trainers. Task trainers are machines that represent physically part of the body. For instance, in this case from medicalx.com, this is a leg that is used to train special orthopedic intervention, but just with a mannequin of a leg. Then we have full hi-fi mannequins that substitute completely a body or of the patient. Then we have completely virtual simulators in which you don't have any tangible object. You just have a screen, and in the screen you get immersed in another reality that you interact with a keyboard, with a joystick, or with any commandment. And the extreme will be the VR virtual simulators in which you interact not through a screen, but through goggles. And this is very similar to virtual simulators, but the feeling of immersion is much more intense. So this would be the transition from role-playing to virtual simulator, VR virtual simulators. Okay, some examples of role-playing. We are not going deeper, and some example of high-fidelity mannequins that we can have. Some companies that are devoted to create these physical mannequins for any specialty in medicine. Examples of mixed reality. Here we have a mannequin, but on top of the mannequin we have put our tablet, and the tablet project some information, additional information. So here, this is a mixed reality because this is not a real patient. This is a mannequin, and this is an augmented reality on top of a mannequin. Or as in this example at right, in which what we have this, in fact, is for ECMO. The users of this is a study, a research paper, in which the author analyzed how to use a mobile phone to put more information on top of a physical simulation on top of a mannequin. And in this case, they could add information about video, information that were images, videos, or 3D models that allowed the user to better understand what they were doing. What's going on in ECC simulation? First of all, let's analyze the skills and attitudes that we need in ECC simulation. So, of course, first of all, we need clinical knowledge. We need to understand the physiology of the patient connected to the ECMO or to the CPB. Then we need to be alert to all kinds of monitors. We need to look at the patient, look at the monitors, look at the lines, look at the connection, be constantly looking at everything. Then we need to know perfectly the procedure. So we need to know what we have to do step by step. We need to communicate. Communication is a key and essential point of simulation. More than 30% of the medical errors are due to miscommunication problems. So we need to communicate. Going on bypass. Yes, I'm going on bypass. Okay, I've understood you are going on bypass. That's very important. Then troubleshooting happens. And what do we need to do to solve them? And after proposing our solution, we need to check if it works. And after checking if it works, what we need is to eventually add the improvement that we have tested here into the procedure that we will use in the next intervention. And hopefully, if this all circle has worked, maybe we have created new new information, new knowledge that we would like to share with our community. So we will publish papers, research papers, telling what we have been doing around. This is the whole circle. And from our point of view at Vermedex, what we need to do is to give advice, support, and simulation training in all of these aspects of ECC. If we go a step further, what are the basics of I'm not gonna go through the whole table, but just for us to have clear what we need to train. In ECC, basics, we need to prepare the case, make the patient review. We need to mount the pump to perform all the heparinization and monitoring of the heparinization. We need to know very well the cannulation, even from the point of view of the nurse who is not going to cannulate, but she needs to know what the steps of cannulation are being done. We need to initiate the bypass, maintain the bypass. Then we need to know how to manage the cardioplegia and the temperature. We need to be very aware of the acid base and blood gas management. And finally, we need to know what's happening in the weaning and post-bypass to administer protamine. This would be the basic concept that we need to simulate. And in addition to that, all this troubleshooting that we have put here, massive air embolism, pump failure, oxygenator failure, arterial cannula misplacement, and many others. Some of them, as you can see, are critical. Actually, they are all critical, but some of them are very life-threatening. And some of them are very common. So it is easy for a professional to be exposed to one of these cases. Some are very rare, but because they are critical, we absolutely need to be trained to those. And not once in life, but periodically, at least one time per semester. This for CPB. What happens with ECMO? The same. We need to know the indications and patient selection to go on VV or VA. We need to know the types of ECMO and configuration, the circuit components. We need to know how to initiate, how to monitorize. Of course, again, the blood gas interpretation, the management, the anticoagulation, and finally, the weaning and the cannulation. And the same as in the previous case, teamwork and communication. Teamwork and communication is different in the case of ECMO because there are many actors and it's not during a surgery, but along days and days. So many people are involved that not necessarily know everything about the case that you are holding. And this is a list of incidents that can happen. Again, some rare, some common, some occasionals. From air entry, pump failure, recirculation, hemolysis, the typical very negative P vent, high P post, high delta P. We need to know how to manage all these kinds of incidents. Oh, I think that we have problems here with the images. No, it doesn't matter. So If we recall the diagram that we were seeing before, from reality to virtuality, so we have screen-based simulators. Here we would have an example, it's Harvey ECMO, in which you have really a 2D screen and you can test and train your skills in the hemodynamic model. Then we have virtual mannequins. Examples of AR, the examples I was just showing you before, which is done with HoloLens. As tax trainers, we can have an example, which would be the Cannula Man. Hi-fi mannequins, of course, the Orpheus. Virtual simulator, VSCPB, or VSCPB VR. We are going to talk about them. Just a brief review of this. In heart-lung simulations, we have Califia, Orpheus. We have this simulator that it's much more on the part of cannulation than the management of the heart-lung machine. So these are the main devices that are being used. There is a lot of literature that have validated the use of these devices from a scientific point of view and also from a pedagogical point of view. There are also other prototypes. So if you look at the bibliography and you look for simulations of heart-lung machine, you will see many papers like this one from 2009 or this one from 2023. Something that we can observe is that sometimes researchers create simulators, but then going from these prototypes that are valid for science to a ready-to-market software or hardware, it's very difficult. So these are examples that are very valuable from a research point of view, but these are solutions that have not yet or will probably never go to the market because, and we know that it's quite difficult to enter in the market. Virtual simulators of heart-lung machine in a commercial way, basically it's VSCPB. We don't know other virtual simulators for heart-lung machine that are in the market. We will make a small demo about this product, and it tries to address the different steps of the generic management that we have shown before. So preparation, going on bypass, hyperonization, management, cardioplasia, and winning, and some incidents. It's a product that will always evolve because Vermedex will be adding new incidents every year or every 6 months. For the ECMO, there are many physical simulators for ECMO, probably because it is a device that is used in more centers in a wider setups. So of course, Califia is one of the most commonly used. We have Eigenflow from CLR. Parallel from Chalice. There is a very nice ECMO simulator from Germany. I don't know if they have market in the United States. Also, a medical simulator from Spain, Hybrids Vita, that is has just been launched to the market. ECMO Trainer 3, ECMO Trainer Professional MK2, and there are many others. So a disclaimer, I am just reviewing the most important ones, but there are many others. And from the virtual point of view, purely virtual simulators, we have basically two. ECMOSIM from Practico Santé, which is a French company, and that provides an immersive virtual environment in which you can touch a lot of devices. And Vir ECMO, that is conceived which is from Vermedex, and that is conceived as a full training program with interaction and social communication with different characters. Okay, about gamification, because we would like to specify the difference from some simulators to the others. In the virtual world, we used to add to our virtual simulators the concept of gamification. Gamification is basically to add game elements, game mechanics to non-gamified activities. So in a simulator, adding gamification is on top of the physiological model of the system patient machine, on top of the interaction, the devices, adding elements like time, lives, points, score, penalties, rewards, also a story and narrative, what happens to this patient, levels of difficulty, a lot of feedback, rubrics, guidance, and also some elements of hazards. You don't know what's going to happen in that room, and sometimes things happen and sometimes they don't. So some of the simulators add these elements, and why? Basically to motivate. It has been demonstrated that a gamification in education provides better and deeper understanding, because we are challenging people and we like to be the best. We like to compete, and competition motivates us. And the points that has make us not be the better, the best or the winner, is the point that we will memorize forever, is the point that will make us remember forever. Wow, I didn't clamp at the right moment when the surgeon was asking me to clamp. So it's a deeper, and for that I lost a point. Huh? So it's a better and deeper learning, and what is more important, and longer retention. Because we have a lot of information nowadays, we are exposed to a lot of data, a lot of things, and it is easy to forget the concepts. So gamification will also provide us these longer retention aspects. Okay, so let's do a little demo. This would be what we would see with virtual reality glasses, goggles, with the VIR CPB program. So you can see the menus a little bit distorted because we are seeing them with the goggles. So at the beginning of surgery, everything happens like this. You can interact with the object with the ray. So you have a joystick in your hand, and the characters will talk to you.
One moment, please.
At each moment, you have to choose the correct answer. So in this case, you have decided to go on BiPAP. You have clamped the line when it was not authorized.
Now you can divide the AV loop.
Okay. Can you confirm that all shunts are closed?
So you have to check if the shunts are closed. In this case, you already know.
Yes, all shunts are closed.
Okay.
So we have communication. You have, again, when we were looking at
Loop divided.
all what we need to do, we need to communicate. We need to check the monitors. We need
Are
to
you
know
ready
the
for me to
physiology.
simulate the patient?
Can we cannulate? We will go and check the ACT. Maybe
Yes,
the ACT
correct
is correct,
ACT.
maybe no.
Okay.
This is the kind of thing
Can
that
you
we are
turn on
going
instructions,
to
please?
see. So VR here will provide us an immersive experience,
Sucker.
and
Okay, the cannula.
we can have the same simply by using a normal terminal. So what I would like to do is to just show you very briefly the platform to see how it is. So let me enter. This would be the platform of Vermedex, in which you have the different products. You have many products. Some of them are already, some of them are already visible. So let's start. I'm going to look for ECMO. So with this, I would enter in an ECMO training, and so here I'm loading, and you will see what the program looks like. So what I've just shown to you previously were videos. This is a real life demo. We are not going to make it full, just for you to see what you see. Great, so this is your ECMO. It's to train ECMO. Currently it's for ECMO VV only. And well, okay, it doesn't matter. This is a demo, but here we have as many, we can have many parts of the training program. So we train all kinds of incidents. Let's just see how it is, just to see the environment and the kind of activities. So you enter here, you have different characters, and you will have different missions.
Hello. Your shift is about to start. Are you ready?
So again, importance of communication.
Yes, I'm ready.
Here you see
Great.
you have points.
You'll go to room 1 and check if everything is correct. Check at the ECMO and the ventilator settings, but do not change them. Review the patient's data. If you find anything wrong, call me.
It is me
There is a
who I'm,
phone on the ECMO card.
it is
You
me
have 2 minutes to solve the
who is
case.
moving the camera.
Is that understood?
So yes, I've understood.
Yes. Perfect.
I will not be long, and just for you to see. We're going to enter in the room, and maybe you are going to detect by your own something that is wrong, or maybe not. So here in the ECMO setting, we have 4 rooms that correspond to 4 different levels of difficulty. And here we have the room with the patient in ECMO. And we will have to, first of all, analyze the data, the last ABGs, the data of the ECMO. We'll have to look at the monitors and try to understand what is happening. And I'm not going further. You can see that probably something is wrong here in this setting. The settings change from one patient to the other. So each time you enter in the room, there is a different case. And basically, that's it. I'm just going back here to the presentation. And yes, basically, these are the characteristics of these simulators, ECMO VSCPB. We also have an AI agent that we can use inside and outside the simulator. And it's a virtual cloud-based simulate platform. So you can use them anytime, anywhere, as many times as you want, as long as you want. And that would be it for the presentation.
Thank you so much, Dani. Wow, that was incredible. Do you need a sip of water? I know sometimes it can be a lot with those long presentations. So I have some questions for you that I'd love to just go a bit deeper on some of the topics that you shared today. I loved the simulation and the actual examples of what it would look and sound and really feel like. So my first question for you is, how would you approach modeling physiological responses? So for example, like pressure or flow or oxygenation when you're in a VR environment.
Oh, sorry. This is, I haven't turned off the game. So what was just happening is that after being there, the nurse in charge of the ECMO was calling me to say, what's happening? Have you done something? What happens to the patient?
They're still going. Would you like me to repeat the question?
No, I understood. Sorry.
Okay, no problem.
So yes, our physiology. So we have a physiological model that modelizes the system patient machine, and it is based mostly on state-of-the-art equations about pressures and flow, but also on data. We have collected data from the hospital with which we work, and also from the bibliography. And where the equations do not arrive, we use data that allow us to extrapolate feasible behaviors of the patient.
Thank you. That makes a lot of sense. What about ensuring clinical accuracy and realism while also maintaining usability for trainees as they come into this workplace for the first time and they're needing to now learn their skills via these tools? How can we make sure that they're very accurate and real, but also usable?
That's an excellent question. So we have the developer team is mostly based by engineers.
Okay.
Most of them biomedical engineers that already have a background in this field, but we have a team of specialists that are perfusionists and anesthesiologists that help us. So each time we develop a task, they test it and tell us what needs to be changed. And also our clients, I have to say, at this moment, we are very happy that our clients suggest us uh, modifications. And the advantage of our platform is that it is customizable and it is very easy to scale and modify. So whenever there is an error, we can change it, modify it. And errors we haven't found so far, but yes, things that should be rephrased or presented in a different way. So whenever we have suggestions of this type, we introduce them as fast as we can.
It sounds like there's a very quick feedback loop where you're able
Yes.
to iterate on anything that you're learning in real time. So that's excellent. Are you able to also design in a way that you can measure learning outcomes within this VR training program where you can actually see in a very specific way how well they're learning this information?
Absolutely. So I haven't shown it because the demo went has when doing demo I jump over what I have foreseen at the beginning. It doesn't matter, but if you go to the platform, every user can see all the simulation he or she has done, where he or she has failed, what she has done well, what she has done badly. And this information is also available for the directors of programs. So as a director of program, you can have a complete report of what your users have been doing. And the score is also a quick way of knowing what's your position in the global ranking of
Hmm.
users of the platform.
Okay, there's also a global ranking. Very
Yeah.
cool. Off, Often there's multiple people involved, right? Like there's a perfusionist, there's a surgeon, there's an ECMO specialist. So what options exist to have multi-user or like collaborative VR sessions right now?
Right now, we don't support collaborative VR. So
Okay.
uh, for a teacher, we have worked on that, but it's still not available on the market. What we can do is you as a teacher, you can share your screen and stop. We have introduced a stop button, so you can stop and ask to your students, so what are you going to do now?
Mm, that's a good solution in the interim. Okay, what
But
about
yeah, but we will work on that, huh?
okay. What about incorporating AI and machine learning? How are you thinking about those emerging technologies for future versions of this in order to have adaptive learning, which it sounds like you're already doing, but how can you incorporate these AI and machine learning tech?
So first of all, it's important to know that our software development is fast because we are using a lot of AI to
Okay.
create the games by themselves. So our platform is basically based on AI. Second, we have been working on a specialized chatbot, Dex, that is an expert of perfusion. We have created a layer of information with pre-selected papers on top of any chat, actually. And this chat is also able to make precise calculations. So what we have done now is that we have embodied this chat within the simulation. This is not yet available in the market because we are thinking about how to introduce it. A fear with AI is if you rely too much on AI, then you don't rely on yourself. So for instance, in VRCPB and VRECMO, we don't put the alarms of the machines. In some tasks, we don't put the alarms of the machine because we want our users, our trainees, to be able to detect the problem without having an alarm. So having this coach that knows everything is useful, but we are thinking how we can gamify it so we also teach people to take into account what AI says, but rely mostly in yourself and the rest of the team before
Well,
AI.
yeah, I'm so glad you're thinking about that because unless we think about those things now, we could put ourselves in a situation where it's exactly that. We are too dependent on these technologies and we stop using our own skills, especially when they matter most. So that's really great. What about a user who has no gaming background? Like, how do you think about them being able to easily navigate these types of VR environments? Do they need to have a gaming background? What do you think?
So absolutely no gaming
Okay.
background, and it's fun to see that people that have never played have used our platform in front of their children, and the children are amazed by seeing their parents playing as they do. So that's fine. So what we do is we have tutorials that are really part of the training program. So you learn how to use the technology. Then we have helps. So at any point in which you get lost, you just click on the help and that's it. And finally, we also have avoided free navigation in the environment because we have seen that people do not know how to navigate. So what we have added is a teletransportation button, so you can change your position within the virtual environment in selected position near the patient, near the ECMO, behind the ECMO, or near the surgeon. And this is just a click. So you don't have to know anything about gaming.
Okay, that's good to know. What about post-deployment support? So what type of like updates and maintenance are you able to provide ongoing for the users and the teams working with these tools?
That's the good thing of having a cloud-based solution. We are
Okay.
continuously improving the solution. So for a user, it's transparent. We update the version, but of course, your score, all your performance, all your history using the simulator is kept. But suddenly you enter, oh, here they have changed the pump, or here they have new drugs that were not here previously. And this is actually part of the engagement of the users. So even if you have passed a task, you should re-enter from time to time because there are always modifications, always improvement and enhancements.
Okay. My final question for you, I'd love for you to leave us with maybe a story, a case study, an example where you had a really challenging medical simulation project that you had to work on. Maybe talk us through some of the problems that you faced and how you were able to solve them. And this will be our final question for you. Thank you so much, Dani.
Perfect, thank you. We started with VSCPB and then we went to VRECMO. And the challenging part of VRECMO for us was that we had to manage 4 physiological models at the same time because we wanted to have 4 rooms. By now, there is only 1 room unlocked, but the idea is you, as a nurse or as a doctor, you have to keep in mind what happens to 2 patients at the same time. And this is quite new. As far as I know, nobody has multiple patients at the same time. And this was difficult to implement, not only from the point of view of the interface, but also from the point of view of the physiological model. This was a serious challenge for us.
Okay. Well, Well, thank you so much, Dani. We
Thank
will
you.
we will include links to everything that we've talked about today, where people can learn more about you, your work, and of course, this amazing technology. So thank you so much for being here and for everybody who has tuned in to today's conference. This has been brought to all of us by Heartbeat Perfusion Solutions, which is a national provider of ECMO oxygenation services. They offer critical support for cardiac surgeries and patients who require advanced life support. I have a little slide that I'll close us off with if you would like to learn more. And we also have been doing multiple of these events now. So we've been able to speak with some incredible leaders in this space, like Dani today. So all of those are now on our YouTube channel as well as our website. So be sure to learn more at heartbeatperfusion.com. Thank you so much for being here.
Thank you.
Bye.